Well, good morning, Carl, and thank you very much. And it's nice to visit with you this morning and talk a little bit about challenges and opportunities in global environmental health. It's what I've spent most of my career trying to do, is to identify the challenges and, more importantly, try to look for some solutions. So what we're going to do today, of course, is discuss agriculture and agrochemical use in developing countries. As you know, right now there's about 7.5 billion people in the world. And by the time 2050 happens, we'll find ourselves with 9 billion people. No additional resources, but 1.5 billion additional people. Every morning when you wake up, there are 250,000 people that weren't here the day before. The pressure on food resources, on meeting the nutritional needs for these additional people each day is remarkable. Now, when we look at the big picture, we realize that there are probably about 900 million people who are undernourished here on the planet. About 900 million. And frighteningly, there are also about 1.4 billion people who are overnourished. So we have quite a challenge on both ends of the spectrum. Lots of places in the developing world where people have inadequate nutrition, don't meet the caloric needs, or the quality of the food is such that they don't get adequate nutrition. And then we have this whole new culture, which we'll talk about throughout the discussion, where people are struggling with poor diet choices, with increases in cardiovascular disease, hypertension, and type 2 diabetes. And so this is a great challenge for us in public health, but we've always been up to the challenge, and hopefully we'll be able to meet it. So I think this picture that we have in front of us, this is a rice paddy up in the north of Thailand, in a way describes the whole picture, the whole set of challenges. First of all, we see the amount of manual labor that's required. Secondly, we see this delicate balance between the environment and man, the ecosystem trying to meet the needs. And thirdly, we see precious resources, in this case soil and water. All of them come together to make the food system. And it's our job to help the people who are the stewards, the farmers around the world, to maintain this balance. And as new technologies come forward, help them implement the technologies, help them understand the risks associated with the technologies, and also help them understand why that technology would be to their advantage. So how do you do this? Well, there's lots of ways to do it. Our NIH funded for many years a series of international training and research in environmental occupational health centers. And we established one about 10 years ago in Thailand for the Southeast Asian region. This is the website if you'd like to go look at Thai Fogarty Itrio Center at Rutgers, and describes a little bit about the project. The way that we worked is that we were based in Bangkok, and we serviced the entire Southeast Asian region with students from all of the countries that you see highlighted in the picture. And so our focus, which is the focus of a lot of the discussion today, is the implementation of new technologies to grow food and the impact, long and short term, on the people who live in these areas. And the example I'm going to give, in public health, you know, we love to give good examples, and hopefully this is a good example. The example I'm going to give is the implementation and the introduction of large amounts of agrochemicals to the production of rice in Thailand. So Thailand is now the world's largest rice exporter. Clearly, China, with over 1 billion people, grows more rice to meet the population food needs. But Thailand meets the needs of its 69 million people, plus lots and lots of others, through their export program. So it's an important agricultural commodity for Thailand. In the 1990s, the government made a conscious decision that they were going to meet a goal to be the world's largest rice exporter. And the way they were going to accomplish that, of course, is better techniques, the introduction of agrochemicals, both pesticides and fertilizers, and that was going to be the way they were going to meet that goal. And in many respects, they've met it. But it's not come without some challenges that we're going to talk about. Look deep into the picture that we have up on the screen now, and you see people with backpack sprayers in the rice paddy applying chlorpyrifos. Now, those of you that know about pesticides know that chlorpyrifos is a potent organophosphate insecticide. It's got quite a low LD50. It's a serious neurotoxin. And you can see the application technique. When you first look at the farmers making the application in the rice paddy, It's actually really interesting to watch. It almost looks like a ballet when you watch the delicate movement throughout the field back and forth. But then as a good environmental health scientist and toxicologist, you look more carefully. And when you look more carefully, you start to see things that make you nervous. Look in the front of the picture at the protective equipment, and I use that word very loosely, of the applicator that we see. Just has cotton wrapped around her face and over her head to act as a protective mask. Okay, there's no respirator, there's no gloves. If you look a little further into the picture, you can see the gentleman with the same kind of white headgear, a white cotton covering, and the pesticide being dispersed pretty aggressively. So in the 90s, Thailand decided they were going to go ahead and increase agricultural chemical imports. And if you look at the top line of the slide, you'll see from the period 2000 to 2010 a steady increase, a remarkably high increase of pesticides, both fungicides, herbicides, and insecticides over time. Okay, the numbers continued to grow. And after people started to look at this large importation of pesticides, which started in the 90s, that data was from the decade from 2000, you start to see that their Bureau of Epidemiology and the Ministry of Health wanted to look at cases of pesticide poisoning. Remember, this was a new technology for them. While farmers had used some pesticides over time, remember, too, that rice has been grown in this part of the world for millennia, but the pesticide introduction started not too long ago. The organophosphate insecticides, these potent neurotoxins, made their way in fairly recently. And you can see with the data from the Ministry of Public Health, a fairly significant number of cases per 100,000 over time. It dropped a little bit in the middle of 2005 and then is back on the increase. So folks wanted to understand what they needed to do to train the farmers, to educate them, and to have them understand the risks and challenges associated with using these chemicals. So one thing, of course, in public health that we try to do is monitor and screen and surveillance. And you can see over time, as people started to look at farmers that had abnormal acetylcholinesterase levels, cholinesterase, remember, is the enzyme. We usually measure it in blood. It's fairly straightforward to measure. You can do field tests. And we saw a marked increase in the number of farmers who had a depressed cholinesterase level. So much so that, like everything, when a new government came in, they were not happy with these data, and so they stopped collecting the data. And you can see for the period of 1 4-year term, the data wasn't collected. A new government came in 2007, and the data started to be collected again. And as you can see, the trajectory, the increase in the number of people with abnormal cholinesterase levels unfortunately increased. And over time, we still see that trend. So that was one indicator. That is a challenge for us. We have before us a technology. We see improvements in crop production. We see improvements in the quality of the crop, but we also see a risk to folks. So let's look at some case studies with that as a way to frame it and see what we've done. And how have we carried out these case studies? Well, one of the ways we've done it, of course, is the training component. Our ITRIO not only provided training to farmers and to researchers, it included training of graduate students. And this is a very proud graduation day at Chulalongkorn University's College of Public Health Science. And nestled in that group of students are students from 7 different Southeast Asian countries, and one student, as you can see over on the right side of the picture, who is from West Africa. So those are our hope. Those are our mechanism. Those are our tools for increasing awareness and decreasing the risk associated with pesticide problems. The second thing that we did, which is a very important public health technique, all of us are engaged in it, is to run workshops. And this is just a slide to give you an appreciation for some of the workshops over time. Some of you may recognize some of your colleagues in these pictures, Dr. Michael Gotchfeld, Dr. Nancy Fiedler, Dr. Howard Kippen, Dr. Bernard Goldstein, and folks from around our region, all of whom I cajoled into coming to Bangkok to participate in these important workshops on occupational and environmental health, causes and prevention of environmental disease, understanding risk assessment, and more importantly, I think, trying to get these young scientists to take that information and talk about analytical methods and scientific writing. It really is one of the great challenges. As we develop a cohort of competent young scientists, both trained in country and trained around the globe. When they go back and start their careers as young scientists, they need our help so that they can become successful in writing high-quality papers, understanding the results of their research, and taking that forward for the broader audience. So let's go back now to some case studies. This is one of my favorite pictures. This is a picture up in the north of Thailand, and this is a farmer. This is a farm worker, actually, on a farm that's growing citrus. You can see they're very tall citrus trees. You can see how they're propped. Some of these trees are close to 60 and 70 feet tall. And so when I got out of the car with the researcher from the university who was my host, immediately this worker put on that mask. It's a dust mask. Now he's spraying azine phosmethyl, or glutathione. Some of you know that compound. It's a very potent organophosphate, LD50 about 25 or 30. So it's pretty hot material. And he's applying this to these trees, and he's literally drenched in the pesticide. So I said to the farmer who was there, I have some concern about your worker. And he goes, oh, no, he's fine. It's not a problem. And, there's lots of workers. If he gets sick, I can just get another worker. I think one of the challenges that we find in developing countries, particularly, is that the workforce is fairly expendable. The standards that we appreciate here in the developed world are not in place. And in many cases, the folks get sick. They have very little recourse if they find themselves ill. And we have to try and help put in place not just prevention programs, but also programs where the workers themselves become more aware of what the risks are. So here's a survey that we did for some farmers in Thailand, and it's translated back into English so that we can view it here today. It's administered in Thai. And it says, what kind of protective equipment do you use when you mix and load pesticides and apply them? And the number one answer is none, which, by the way, is the number one answer in many parts of the world. But then I want you to look carefully at some of the descriptions of PPE that are used in developing countries. Normal mask or clothing mask. Now, that's that cotton drape that you saw in about the second or third slide. Then one that really baffled me, knitting faces hat. And I couldn't quite understand what that was. You'll see it in a minute. And then one that kind of made me chuckle is number 5, loincloth, sort of the Tarzan approach, I suppose, to pesticide application. But you can see there are some traditional PPE items here, much lower on the list, that we would typically use, along with some things that are not particularly helpful and, in fact, could long-term be a problem. So here's our applicator with his knitting faces hat. You and I know this is a ski mask, something that, Mom put on you when you were a little guy and went outside to play in the cold weather to protect you from the cold. Here, in a place where it's probably about 100 degrees Fahrenheit in that photo, is this farmer wearing the knitting faces hat. In his mind, he honestly thinks that this is protecting him from pesticide exposure. You also see he has a cotton shirt on and cotton shorts, short shorts, and no shoes. And he's ready to go out and make the application. And you see our little air monitor tucked away on his shoulder. The thesis project for this master's student was to look at the pesticide levels in the breathing zone of this farmer during his application. And not necessarily my first choice on how to measure it, but this is what was approved and went forward with the IRB, and so this is what we did. Now, I asked him how often he washed that mask, and he didn't wash it very often. So you and I know, since it is cloth material, that it actually, instead of protecting him, becomes a sink and will, in fact, have, over time, a fairly high level of pesticides that are resident in that mask. He also has the cotton shirt, which is quite absorbent, and the cotton trousers. Now, I have to tell you, one time when I used this slide in a presentation to a group of medical residents, and I was presenting, one of the residents raised his hand and said, well, Dr. Robson, you've missed the point, which I thought was kind of an interesting way to start the dialogue. And I said, Doctor, how might I have missed that point? And he goes, well, if you put these folks in Tyvek suits, then you won't have to worry about all this, and you can just zip them right up. So I reminded them we were in a place where on a cool day it might be 90, and it's not unusual to see temperatures of 105. So I agreed with him. A Tyvek suit is one approach to reducing pesticide exposure. But the challenge is, in a place like this, they would die in about 35 or 40 minutes of heat exhaustion should they have a Tyvek suit, number one. And number two, even if they had one, they wouldn't be able to replace it because they probably couldn't afford another one. So we have to sort of work with the challenges that we have before us, and one of them, of course, is constant washing of hands, washing of clothing, soap and water, those sorts of things. The other approach, of course, is to train the farmers, and to train them in a program where they understand in a very hands-on way what the risks are and how to remediate them. So this is graduation day from our 2-week training course that we held. This is in a rural health clinic in a village in the south of Thailand, and I was the graduation speaker. Here are our team of farmers, and then on the other side, the 2 women are my colleagues who, of course, are presenting this information in Thai to the farm community. You know, when we do training, whether it's training graduate students, whether it's training continuing education for health professionals, nurses, PAs, and physicians, whether it's training emergency response people, or it's training just lay people, or in this case, farmers, it has to be done in a way that people are comfortable and understand it, and it's relevant. You aren't going to be able to ship these farmers off to the university. You have to bring the program to them. So here is our program brought to the rural health clinic. It's a nice, open, spacious area. And one of the things that we invited people to do, of course, was to diagram and map their farms. Now, the farms are usually quite small, a few hectares. So they're not large farms like we have here in the States. They're pretty modest size of a few hectares. And there you can see in this gentleman's map his home and where he located his well and the area where the crops are actually grown. And one of the exercises here is we ask them, okay, then how close to the house do you spray? Where do you mix and load your pesticides? How close are your children playing? These are all important aspects. Then we have them build a diorama with materials that we had there at the health clinic. Nothing fancy, as you can see. And you can see the candy wrapper becomes the roof of the farmhouse, the jar lid becomes the well, and my most favorite thing in this picture is the elephant. Now, I visited this farm 3 different times in search of said elephant, and I never saw the elephant, but the farmer insisted that he had an elephant nearby and that the elephant would come and bother his crops. Nonetheless, this was a way for him to show me in a very visual way, and more importantly, show himself and his family where the crops are, where the risks are, where the pesticides are used, what's the relationship with that exposure to the children. It really was a very important way to put it together, and then we went on farm with the diorama to see how well it matched. One of the things that is a challenge in global environmental health is the difference in culture, and in this case agriculture, and the husbandry activities of the farm community versus what we know here in the States. You know, many of us that are on the webinar today are trained in environmental occupational health here in the U.S. We go into plants and we work with workers where they have very high standards, and you know, we have a goal that we go after as far as levels of certain chemicals and exposure limits and PPE that's available. We find ourselves with very traditional kinds of occupational settings as well as some non-traditional types. I would hazard to say that almost every occupational setting that I have encountered with my global work, I would describe them all as non-traditional. And this is the case here. These are maize farmers, or you and I know of them as corn farmers. And what's remarkable in this community is that they farm as a community. There is one very large planting of maize, and each person in this village participates. It is communally harvested and stored. The proceeds are distributed in a communal way. So the good news is once you engage the community, you literally have everyone in the community. And you can see the poster. We're going to go in a little more detail here of what we did. So this is Denpeng, the tall person on the right next to the farmer. And Denpeng was a provincial health officer, and he was my doctoral candidate. And we were trying to use very practical applied PPE. So what can you do in such a warm environment and still make a difference and reduce pesticide exposure? And so we found that we could get away with gloves, cotton clothing that's routinely washed but long sleeves, a mask and goggles, and a hat. This was about the most basic PPE that we could provide, and then as we did analysis and exposure measurements, saw a reduction in pesticide exposure. They used several fairly potent insecticides while they were protecting the maize, as well as two very potent herbicides. So what do? Okay, you got some protective clothing, and then you have to be a good public health person. Public health is all about getting out of your office and getting on the ground and getting in the community. So we made a poster, and we vetted the poster with community leaders several times till we got the technical information that we thought we had to have in the poster, and still had it developed in a way that we knew people could visually mostly understand it. And then our campaign was that every home in the village, and here's just 4 examples, every home in the village had this poster. Usually had it in the kitchen or an area near where they kept their pesticides. Notice I said in the kitchen, an area where they kept their pesticides. The most frequent place that people stored their pesticides was in their kitchen, which was a little scary. We also had a public awareness campaign with billboards and large banners in the community. And what was interesting to me, when I mentioned to you this was a fairly remote place, I was not exaggerating. They have cell phones. You can find a mobile phone almost anywhere in the world, but they had no television and only limited electricity. The news was read aloud to the community every afternoon at noon. So during lunchtime, when people took their lunch break, the lady read the local news. What's going on in the country, regulations and rules, items of interest. And she also did a public service announcement each day for us about reducing your pesticide exposure. So this is our very aggressive public relations campaign that we provided for folks. We spent a lot of time on most of our projects looking at the risks associated with farmers. But as you and I know, farmers are not the only people in the community that can be at risk. One of the second phases of our efforts was to protect the next generation. Now, these are fairly new tools in the toolbox of the farmers in this part of the world. These fairly potent organophosphate insecticides and some of these newer herbicides. And so people weren't used to applying them. They hadn't seen problems associated with their children because we had gone generations before people actually were exposed to these. So this is a non-occupational study that we did. We focused this time on children, again in the south of Thailand. And the first name on the slide, Chitatai, is our PhD student. She's now a faculty member at a smaller university in Thailand. And then her research team, 2 local faculty, and me. And what we realized when we did observations is that the children are close to mom and dad throughout the day in the field. And you can see the little ones right in the field with mom and dad, on the side of the buildings, with the animals, and also just playing in the field. All of these little folks were at risk, and we were concerned what their exposure might be. So when it comes to child exposure, one of the easiest ways to measure it, and to be fairly non-invasive and also not to put off the engagement of the community, is to do urine samples. Children in Thailand and most Asian countries are toilet trained at about 1 year of age, 1 or 2 years of age. It's really a very good thing when you're a researcher measuring things in urine. I always like to tease and say in the United States, little girls are toilet trained at about 3 or 4, and boys at about 25. But in Thailand and other Southeast Asian countries, 1 or 2 is about the time that children are able to use the toilet. So we were able to collect urine samples on children in the village and on children on the farms. And here you can see dialkyl phosphate metabolites. That's a very common set of metabolites for organophosphate insecticides. And it's in micrograms per gram creatinine adjusted in kids during the dry season. Now, the dry season is when the crops are growing and the pesticides are applied. And the light gray bars are the kids who are on the farm. The dark gray bars are those children who live in the village who are not associated directly on a farm. And you can see with these 5 metabolites, that we have an increase in their exposure based on what we harvested from the urine sample. If we move to the rainy season, here we call it the wet season, but the rainy season in Thailand, now the levels of dialkyl phosphates in urine for both farm children and for children who are in the village is about the same. So when there was no pesticide used, we were not measuring any DAP, and when the pesticides were applied, we were measuring fairly significantly higher numbers in the farm kids. So that gave us a pretty good indication that these young kids were being exposed. Further studies in other that we're going to discuss a little later in the talk, we also did some other biological measurements, including some blood samples. But these initial studies were done with urine samples. As you know, most people are willing to provide you with a urine sample. Parents are not put off by asking that. When you start to ask people for a blood sample, you immediately find yourselves with a lot more complications, a lot greater risk, and also a lot more education to the parents to sort of look at the value of that additional sampling. We also followed it up with wipe samples, both on the hands, and in this case we did the feet. Again, it's a cultural thing. In traditional rural families, people don't wear shoes. Or when they do wear shoes, as soon as usually sandals, when they arrive home, they slip the sandals off at the door. You never wear shoes in a home in Asia, and when you enter a temple or any other kind of important building. And so we decided, actually it was a graduate student's decision, that we should also not just do hand wipes, those traditional isopropyl wipes that we do if we're looking for lead in kids in old housing stock here in the States, but we did foot wipes as well. And our foot wipes got some really interesting data. The problem is that we didn't have any reference point, so it's very hard for us at times to try to understand what that foot sample meant. Now, it's interesting. We did time and activity diaries. We questioned mom about what the kids did, and we compared it to what we observed. And this is always a challenge because here in the States, some of you have done these time and activity diaries. You know, you ask mom what her kids do, like how many times they wash their hands or things like that, and then you actually observe the kids, and usually mom is far more optimistic as far as the hygiene methods of her kids versus what happens in reality. I remember years ago we had a project here at Rutgers, one of Dr. Paul Leoy's students was doing, at that time it was a fairly sophisticated study to take videography of children's activities and then through some pretty interesting software parse out the different activities and try to assign risks associated with those activities that was software driven. One of the things that we observed, of course, were how often the kids washed their hands. And in this one segment, we interviewed the moms, and for the little girls, we said to their mom, you know, how often does your daughter wash her hands? And she said, well, about 6 times a day. And the videotape for that period of time, the videotape showed about 1.5 times per day. So mom was a little more optimistic. For little boys, we asked the same question, and mom would say, well, 2 or 3 times a day, and it was more like 0.5. In fact, in videotaping the little boys, it was interesting. They would get in front of the sink, turn on the water, and turn off the water, and not put their hands under the water. So, you know, you have data, and you have information, and then you have to make sure that you can validate that. Just to make you chuckle, I said to you we did these studies during the dry and the rainy season. This is what we did most of the time during the rainy season. We spent an awful lot of time pushing that university vehicle out of the mud to get back on what they were calling a road. Now let's go back to something I mentioned at the very beginning of the presentation, and that is, you know, that this is a complex ecosystem. And it's an ecosystem that competes. As populations grow, the ecosystem has lots more pressures on it. Here is an example of a rural area where rice and vegetables are grown, but also in the canals that are used as irrigation canals, or the Thai word for a canal is a klong, they are also provide a fishing area. So farmers are farming and they're also fishing. It's a very integrated system. I won't call them subsistence farming because many of them are actually quite successful. but I would say it's a highly integrated system where they have many, many activities that contribute to an income so that they can have an acceptable livelihood. And as the resources get more scarce, they're almost forced to be more creative. And also, we've got to think about population distribution. So remember, I mentioned to you before that 250,000 people appear on Earth every day. Okay? That's how much, that's the number of new births each day in the world. And these births are occurring in the developing world. They're not occurring. If you look at population trends in Northern Europe, the populations are decreasing. The birth rates are very low. They're certainly lower in parts of the United States. It's in the African countries and the Asian countries and some South American countries where we see this rapid increase in family size. You only have to look at China to put this in perspective. 20% of the world's population is in China. Okay? 1 in 5 people on Earth are Chinese. And yet, if you look at the agricultural capacity for China, China only has 7% of the world's viable farmland. So it's not a stretch to realize that you have a problem here. You have 7% available farmland to support 20% of the world's population. There is really going to have to be new technologies implemented to support that population. And those new technologies come with some risks and come with a certain number of challenges. But being a good public health person, they also come with opportunities. Opportunities to implement new techniques, opportunities to try and improve the quality of life. So from that picture that you saw before, we decided we would get a handle on the ecology in the food web. And so this is a picture of a causal web. And I put this in not for you to actually try to read this, but to demonstrate to you the complexity in trying to sort out what the food species are, where the chemicals enter into the food species, and how these all sort of intermix. It is a highly integrated, very complicated system. And first thing we were trying to do is measure DDT and its derivatives in these indicator species. Now remember, I mentioned to you that starting in the 80s and certainly in the 90s, we saw a big increase in the newer form of insecticides, the organophosphates. Historically, what compounds had been used since the 1940s, like in the United States, like in Europe and other parts of the world, have been the chlorinated compounds, DDT, aldrin, dieldrin, heptachlor, and those chlorinated compounds that are highly persistent, the ones that biomagnify, the ones that remain in the ecosystem for a very long time. And so while we didn't have a lot of data to look at initially in the organophosphates, we had the chance to go back and look at these chlorinated compounds that have been used for several decades to see what their risk was. In addition to looking at where it fit in that causal web, we also were able to take the time to do some human risk assessment from those organochlorine residues as they make their way into the food chain and what farmers were actually exposed to when they were doing the fishing. And finally, we were able to do some calculations as to, based on dermal risk exposure from being in those clones, what the risks to certain pesticides from certain pesticides might be for certain kinds of cancers in the farm community. And for several, we found some excesses. So we took this data and we helped that frame our applications for additional research proposals as well as for the basis for our exposure and research and environmental training project. So you have all this data. Now what do you do? One of the challenges is you don't necessarily have any baseline data. So here we have farmers. We wanted to see what their exposures might be from their activities. And when we went into the literature, there wasn't a lot of data. We had to write our own proposals and eventually write our own papers. You got to have direct measurements. This is one of my graduate students, now an associate professor and a deputy dean at the School of Public Health, but this is a very young Dr. Watasit Siriwong on his quest for his PhD, interviewing fishermen who are, they grow rice and they also fish in those clones, asking them about how many hours they spend fishing, what they do, how many fish they catch, what kind of activities happen besides farming and fishing. So we had a fairly good and complete characterization of these farmers while they were going ahead and through their daily activities. And then we set a stop back and say, well, how do you catch those fish? It's not like a commercial fisherman here in New Jersey with a large net and a boat. These are folks that are literally in the water. If you look at the bottom right corner of the slide, okay, you can see the gentleman that is down in the water, literally there for most of the morning with his nets catching fish. One of the interesting things that I think is the data point in that second on the right top row, the gentleman wearing the wetsuit. Now, I honestly thought he just wore the wetsuit because I was there a couple of times as the foreign visitor and researcher. But no, in fact, he wore a wetsuit every day. He was very aware of the possibilities of exposure. You notice the other gentlemen are more typical what the farmers were wearing when they were out catching fish. But that gentleman wore a wetsuit, and he told me specifically he was wearing that to reduce his chance of any kind of exposure. So we had to figure out how the fish were caught. We had to pay close attention to this because we didn't have any reference point going forward. So we understood what they did. We understood how they caught the fish. We decided to include a dietary component in one of our sub-projects, and we got a pretty interesting paper out of this. We realized when we called up the EPA Exposure Handbook, a very useful tool for so many of us on a regular basis, that we had consumption data for lots of people, different ethnicities and races and different age groups and all of those things. We didn't have anything that was able to help us here. We had to do a really interesting pilot looking at about 50 families to see what they ate. Now, what was helpful was that the 50 families were very willing. They were happy to consent to our IRB approved form and help us understand what they ate every day. We got some advice from my colleague Joanna Berger. Dr. Berger does a lot of subsistence fishermen studies here in New Jersey and other parts of the United States, and so she gave us some careful guidance on how to approach communities for this information. We first asked them what we thought they were eating, and it just didn't seem like it was enough. People tend to woefully underestimate what they consume. As somebody who is perennially on a diet, until I had to actually daily mark down all of what I consumed, calories, protein, and carbohydrates, I was so far off by about 300%. And if you look at the literature, people typically, if you don't have a good QA/QC in place and just ask people randomly, they tend to underestimate their food consumption between 100 and 300 or 400%. It's really quite remarkable. And that case was not different here with our Thai farmers. So we had these families that for 2 weeks were very compliant, and they literally measured everything that they ate so that we could weigh it out and calculate it fairly accurately. Now, this worked fairly well because the diet for rural people is fairly straightforward, and it consists of fish and vegetables and vegetables and fish and vegetables. So the good news is we did not have this wide range of food that we would encounter if we were doing this study in a large urban area or here back at home. This is a pretty straightforward diet of fish, occasionally some chicken, and lots of vegetables and rice. So we were able to have a very tight study as far as what the consumption was. But going into the study, we calculated that the estimate was off between 150 and 300%. Pretty remarkable. Finally, we got the ability to measure what people ate. And the most interesting thing was that one of the most popular fish is a fish called snakefish. It's very tasty. I enjoy it myself. And part of Dr. Siri Wong's thesis and several other theses is the bioaccumulation of these pesticides, the chlorinated pesticides, in the fish. And it was found that the risk, if we went back to that very complicated causal web diagram, we find out that one of the big contributors to dietary risk was the snakefish. Very efficient in concentrating these chlorinated compounds, and of course highly prized and often consumed by the rural people. It's there, it's delicious, everything was in its favor for high consumption. the outside committee member for this thesis for Dr. Sirawong was actually someone from the Ministry of Health. And they were really a superb public health practitioner. And she said to us, okay, this is a really good thing, but I'm not going to sign this thesis until you agree that as part of your research work, you're going to write a very straightforward information packet for a rural person. You're not going to write a technical report that's going to go to a government agency and get shelved. You're not going to write another paper. You can write a paper, but that's fine. But you're going to write a very user-friendly brochure on how people can reduce the risk. There's a certain part near the liver in this fish. If you cut that out when you prepare the fish, you've removed a significant part of the concentrated pesticide in the fish. Because you know people aren't going to change their habit eating that fish. It's popular, it's delicious, it's there, it's cheap, it's free, it's in the water. So you're not going to change that eating habit. What you're going to change is the preparation method to reduce the risk. And it was just a wonderful public health in action kind of success story that I can take absolutely no credit for, but the person from the ministry suggested it, and Dr. Sirawong implemented it, and we're just very proud of the fact that I think we made a real difference as far as the quality of life and long-term health of these folks. So while we were busy watching the pesticides and measuring urine and measuring pesticides in rice and in food and everything else, we stopped to say, okay, what else is in front of us that is a significant risk? And that what else that's in front of us that's a significant risk are these children on their way to school in the morning. So look at the slide. The children are crossing in the area near where the rice paddy is, where the pesticides are applied, and they are exposed. Their homes are perched in the middle of the rice paddy. The school is on the other side of the rice paddy. And so every day we have a risk for some kind of exposure. So we have talked for 45 minutes. What I'd now like to do is take about a 4-minute break. And so my wonderful technical colleague, who knows how to do this, will stop the webinar for 3 or 4 minutes and give you a chance to give your ears a rest, and if you need a biology break, and we'll continue at, let's say, 11:20. So I'll see you in 5 minutes, okay? Thank you very much for coming to our village for the National Institute of Health sponsored Fogarty program, and he really is quite the diplomat. He's going to do well as he goes through life. And so this is one of my graduate students, Bupa, just doing some basic recall studies. We wanted to do some cursory environmental exposure and neurological testing to try and see what the risks might be for these children in the community. And with that meant a group of kids that were recruited ages 4 to 8 with IRB approval through the university and the WHO, and to bring them in and to just go through this series of normal tests. One of the tests is a really interesting test developed by Dr. Diane Rollman at Oregon Health Sciences Institute. And this is our graduate student, Bo, and she's working with the students. They do a little sequence where they see the number on the slide and then remember the shape that corresponds with the number. This is a sort of a internationally accepted test, so you can also make comparisons not just within the cohort of students that you have here in your village, but with students from other parts of the world where we think we have some pesticide exposure. Really very sophisticated and very adaptable technology that she has developed. One of the things that we have to learn in environmental health, and all of you on the webinar know this, is that we all have a specialty. We're all generalists in environmental health, but we all have a specialty. There's something that we seem to concentrate on, whether it's water or air or soil or pesticides or food. There's one thing that's our most familiar area, and that's a problem sometimes. It certainly was for me. I'm so hell-bent on looking at pesticides as the challenge for all these rural people that I overlooked more than once in my 40-plus year career, sometimes what is pretty obvious to other people. And so I tried to be a little smarter the last 20 years with this project. I didn't necessarily get it right, but I want to show you some of the things that other people helped me understand. And one of them was a project we did with Dr. Alan Gator and Dr. Vera Scotti at Prince of Songkhla University in the southern part of Thailand. And it's these very high levels of arsenic that are naturally occurring throughout the shallow drinking water in Thailand and other parts of the world as well. You know, there are some remarkable levels in places like Bangladesh and other places like that. Dr. Joe Grazioni and the team at Columbia have done spectacular, very elegant work in this area. So this is a small project that we had in our area. And it was because while we were busy looking at neurological effects, we kept seeing a high level of skin cancer in some of these farmers. And the pesticides they were using and the practices that they were using didn't necessarily suggest that that would be a problem. But the shallow drinking wells had very high levels of arsenic. So look at the picture here with me, and you can see a lot of dots. Every dot is a house. The dots that are blue is a house with no well. The dots that are red are levels where there is over 200 parts per billion of arsenic, sometimes up to 1,000. And the yellow dot is somewhere between 10 and 200 parts per billion. It's pretty remarkable, the distribution. And what do you see? The first thing you see, early signs of arsenic exposure is Bowen's disease, this level of speckling in the skin. The Thai people call this raindrops in the sand. But you'll see, because Thai people have more melanin in their skin than I do as a person who's Caucasian, you'll see these little speckles. And that's sort of a precursor to the next step. The next step is a very common symptom of arsenic exposure, planar palmar-keratotic lesions. These raised lesions are a very strong indicator of arsenic exposure. And a number of people in the villages with these high levels of arsenic had this, particularly on the palms of their hands and on the heels of their feet. So you get to see that. And then finally, unfortunately, the remarkable level of skin cancer that you see on the back of this individual who did not survive their skin cancer problem. And so this is a mess. This is a challenge. What do you do? Well, there are no easy solutions. First of all, for some of you who work in regulatory, we spend a lot of time looking for an RP, a responsible party. There is no responsible party this time. It's naturally occurring. I gave this presentation and someone said, well, I think the answer is pretty easy. You dig a deeper well. That is the right answer, by the way, but it's not an easy answer, because to dig a deeper well, you need money. I always tell students, when you're answering an exam in public health and you don't have an answer, don't leave it blank. Write the word money, because money or more research is needed are probably the two most popular phrases that I have used in my 40 working years in public health. And in this case, it's true. This beautiful little boy is taking a bath. This is outside of his farmhouse where he's bathing. And you see he's doing it from a hose. I was there for 2 weeks. I actually washed up back there, too. I have to say that was the coldest water I have ever bathed in my 62 years. But the wells were dug deeper. Instead of these 20-foot wells, they were a couple hundred feet. But it required sophisticated, specialized equipment. It required sophisticated, specialized operators. The typical well in this village, you and I could dig. We get 2 shovels. We start in the morning, and probably by noon, we have a nicely dug well. By the time it's dinner time, there's actually very clean, very clear, very good tasting water in the bottom of that well. And you just dip it in and get out the water. That's fine. The problem is that water that you took out of that well could have 500 ppb of arsenic. The WHO standard, remember, is 10 ppb. Here in New Jersey, our standard is 5 parts per billion. Certainly with 500 to 1,000 parts per billion, we have people at remarkable risk. So this little boy, of course, has avoided the risk. It became a kind of a wonderful experiment. The Japanese government provided the resources to dig these deeper wells, and then the local government provided the piping to the individual homes. And we were able to see, in a very short time, a remarkable decrease in the exposure to arsenic. And remember, too, when water is the matrix that we have of concern, it's water that we drink. It's water that we wash with. It's water that we clean our house with. It's water that we breathe from water vapor when you're taking a shower. Water is clearly one of those vehicles that if there is a problem, it is a multifactorial problem. There are multiple routes of exposure. And to solve that problem was not trivial, but it was eventually resolved, at least in many of the regions. Sometimes people say, well, you can just put on filters. Well, you see how the delivery system is. It's a hose outside. There is no place for a filter, and filters have to be maintained to be effective, whether it's here in the developed world or in the developing world. And maybe I got you a filter to start, but once there's breakthrough and you don't have any money to replace it, probably you haven't done much to fix the problem long term. Here's another one of those learning moments for me. We had a lot of farmers that were growing vegetables in the northern part of the country, and they had serious respiratory problems. Again, there was no apparent reason why they had these respiratory problems until we looked at what else people did. Remember, you got to ask people, what do you do? What do you do, and how do you do it? That's a basic tenet of occupational health. It's that important questionnaire that the nurse or the doctor asks you when you go to the doctor, especially if it's an occupational health related. It's what you do as a health officer when you go in to do an investigation. Surprisingly, a lot of people don't ask that question. I remember going with my father to his GP one time and just saying, Pop, my dad was a farmer his whole life. Pop, did the doctor ask you what you did? Oh, no, he didn't have time for that. I said, well, you certainly have a lot different lifestyle as a person who's been a farmer for 70 years than someone who, was a school teacher or an accountant or a bus driver. I say, farmers have very different exposures. You can't evaluate your health risk the same that you could, quote, an average person. So we have to ask that question, and I guess we asked the question here, and you can see what we learned. These are incense sticks. Farmers grow vegetables and they catch fish, but they also have other businesses to make their income sufficient to survive. And so this is a cooperative where these ladies are bundling and packaging these incense sticks, and they'll go on for export to stores here in the United States like Bed Bath & Beyond or all Pier 1, those kinds of stores where you could buy incense sticks. But let's go back to how the process works. Here's the farmer, but he also is getting ready to make incense sticks. These are all hand-cut pieces of bamboo, and they dip them in glue, and they dip them in the incense, and then they flick their hand like this and make this beautiful floret-looking display so it can dry in the sun. So they attempted to teach me how to do this, and I just failed miserably. So he did not offer me a job. But I was surprised at how much work it is and how much technique is required. But let's go back to the production end of this. So here is the farmer's son. He was about 19. He had a peak flow volume like someone who had been a 3-pack-a-day chain smoker for their whole life. He's really respiratory compromised. But that mask, by the way, appeared about the time that I appeared. So you can see he has the bundled bamboo that's been cut by hand, dipped it in the barrel in front of you with the hot glue, and then this large workbench with sandalwood sawdust, very fine sandalwood sawdust. He hooks the sticks in there and then shakes it aggressively, and then they go out to dry. And so he was busy coughing, and I said to him, it's very dusty here. You have a problem. He goes, oh, no problem, Professor. So I wrote him a note in the dust on his speaker for his radio, and then he just kind of grinned. So here we were trying to desperately find out why we had all these farmers with serious respiratory issues, when in fact it was because of the other kinds of production they were doing. Here's another operation, a little larger. This time you can see the person has the right respirator on, but he has it on his forehead as opposed to over his face. And you can see the dust. He was about 17, this young man. You can see the dust on his arms. His face has dust on it. He had the respirator. The respirator was not in front of his nose or his mouth. Interestingly, this was a little higher-end operation, and they dipped the incense sticks in both yellow paint with cadmium and red paint with lead. So he had some multiple exposures. So what do? You go into the communities, you see some additional risks. How do you make a difference? How do you train? So we talked about training of graduate students. We talked about training of health professionals. We talk about training of the farmers themselves. But we know, you and I know, that the real way to make a difference is to work with the next generation. And so we found ourselves collaborating with charter schools. They call them schools under royal patronage, but you and I here in New Jersey would say they're like a charter school. And here are the 8 principles of this charter school. You have to believe me when I translate for you that the first principle is basically it's God, the King, and country. Thai people are about 97% Buddhist. Buddhism is very much a part of the national identity in Thailand, so it's for your temple, your faith, for the king. Thailand has a constitutional monarchy. Okay, these are very key things, and for Thailand itself, for the kingdom. And then it talks on further about self-reliance and ambition and motivation and so on. So off we went to these schools to see how this works. And in this photo, some of you might recognize Dr. Arthur Frank from Drexel, Dr. Jane Hoppin now at NC State, myself, and Dr. Siri Wong. This is a few years later where Wadasid is already a faculty member. And we're instructing these small community schools, basically we're listening on this particular occasion, to learn about how they're trying to improve the food production and do it in a sustainable way. And again, these efforts are all supported by the royal family. If you look at the photos, the posters on the top of the ceiling, you'll see a picture of Rama IX, the king who recently passed away, in every one of those posters. And so the kids learn how to plant high-yielding varieties of rice, and they have their own little experimental rice paddies. They learn how to intercrop with certain kinds of vegetables that will help them with a balanced diet. They learn how to make organic fertilizer from fish waste and other local products. It really is quite amazing. And, if we go back to this village 10 years from now, I think we'll see remarkable improvements when these young people are the folks who will be growing the rice and the other crops. And just a little lighter note, since we've been together now for over an hour, I think you have to realize the challenges and opportunities in global health mean you have to get to appreciate the folks and the local people and what they do. And this is a small concert given on our behalf with traditional Thai instruments. And these were spectacular young musicians. I mean, as a dad, I've sat through some pretty less than stellar high school and elementary school concerts, but you're compelled to do that as a parent. But I have to tell you, when these kids started to play, I was in awe of how wonderful and how beautifully they played. But things took a turn for the worse. They had some audience participation. And as you can see, the large farang, as we say in Thailand, the large foreigner, clearly had no musical talent. That was my just a little attempt at some humor. You got to know what the people think about their risks. This is a picture in China. And this is meeting with farmers in Hebei province in China with a project I have with the Beijing Institute of Technology. And Dr. Reifah Hu is the gentleman to my left in the slide. And we've been looking at agricultural exposures and food production in China. What makes China so interesting is they've taken a completely different approach than their neighbors in Thailand. But you have to go into the community and meet with the farmers. I have to tell you a quick little story as we get close to the end of our webinar. I introduced myself through my translator, the young assistant professor to my right. And I said, I want you to introduce exactly how I asked you to do this. I said, tell them how happy I am to be here because I'm a farmer too. And they all seem to be happy about that. Farmers are always very gracious with their farmers. I said, but my pop farmed his whole life, and I don't think he ever had a good season. If you ask my father if he had a good season, he'd say no. Now, I know a little bit of Chinese, not too much, but I said, so was your season Han Hao, a good season, or was it Bu Hao, a bad season? And without question, everybody Bu Hao, Bu Hao. So whether you're a farmer in New Jersey, or a farmer in Hebei, or a farmer, I'm sure, in some other part of the world, I don't think farmers have ever had a good season in all the years they've farmed. But and I also think it's kind of cute, that when you go, you are typically offered both cigarettes and green tea. I was the only person not smoking in that meeting, and I was just coughing up a lung, so finally someone said to me in very good English, here, if you smoke, you won't cough as much. I said, I don't think so. But we worked hard with the farmers to see what pesticides they used. We found that they used very little pesticides. Their focus was almost exclusively on the use of GMOs. China feels very strongly that for their large, important crops, like peanuts, like cotton, like maize, and other big export commodities for them, they're going to use GMOs. But we did have these elaborate very user-friendly calendars. And on one side were these very pretty pictures that the local community contributed from scenes in their community. And on the back side, the graduate student, let me go back for a second, that's one of our graduate students. The graduate student met routinely with the farmers every other week or so and recorded what they had applied so that we had accurate and appropriate information. You know, as a health professional, that when we try to get a good history about what was applied for pesticides, very often when we ask someone what they applied, they give us a trade name that doesn't give any indication what it might be. So we had the farmers bring in the product and we recorded it appropriately. On a lighter note, too, you have to understand local custom and culture. This is the community leader who stood up and gave a little speech and said to me that this was one of the most exciting days that he has had in his life because he had never met a foreigner. This is not that a remote province, but it's certainly quite a ways outside of Beijing. And he asked if he could get up and give me a hug. So I said, of course. So I stood up and did that. He was not a farmer. He was the local Communist Party community leader. And then we subsequently hugged everybody in the village. 76 people later, we went back to work. This was amazing to me. These are genetically modified rubber trees. The farmland in China is owned by the state. The farmers rent it for about a 5-year period. And they like to grow rubber trees because the first 3 years the rubber trees grow very aggressively and they produce rubber. And then the 4th year there's a pretty good rubber crop. And the 5th year you cut down the tree and you can sell it for wood product, for furniture and other things. But these are GMO rubber trees. This is GMO cotton. Okay, genetically modified cotton. They applied almost no pesticide, and China has become one of the world's largest cotton producers and exporters. All right, as we come into the home stretch, one of the things that we learn in global health is that we can train and prepare for lots of things, but there are some things that happen that you just can't be ready for. One of the most amazing things in my experience was the tsunami that happened in December 2004. Some of you remember that. And this is an email from one of my graduate students. I was very worried because I hadn't heard from them, and I was worried that they were safe. And so they had volunteered, as you can see, and they went into the areas affected, and they helped people rescue. It was devastating. This is Phuket. And some of you know Phuket is an outstanding resort area, a beautiful area where lots of movies and things are filmed, and it was just literally, it was leveled. This is a recovery area in a Buddhist temple where they set up time to put pictures of people that were recovered and tried to be identified. This is the entrance to the clinic, and the young Thai medical students take the vitals and the history from the community and then send them off to the doctors. And I like this picture because this is a farmer, and I asked my medical student who was translating for me, I said, he looks pretty well. I said, what is his complaint? And I said, oh, Professor, he doesn't really have a complaint. He lives up in the mountain. The tsunami didn't affect him directly. But in 1979, his water buffalo stepped on his arm. And there had never been a doctor in this village. So he came down in 2005 and asked the doctor to look at his arm that was stepped on by the buffalo in 1979. So you get an appreciation for the lack of regular health care in a lot of these remote places. This is one of the great challenges. This is a doctor from University of California system who volunteered. The young man next to him is the medical student, the friend of the patient, and the patient. How do you feel? 1, 2, 3, 4. My stomach hurts. 4, 3, 2, 1. This went back and forth. The doctors, the nurses, and the medical students were absolutely exhausted by the end of the day. Interestingly, in this particular case, after the initial tsunami hit and thousands of people were killed, the rest of the health problems that went on for months were things like contact dermatitis, gastrointestinal disease, and a whole host of things that you might expect would happen after a disaster. I just saw the whole thing as being a disaster and with no hope of recovery, but once again I was very wrong. I returned a few months later, and up popped this laundry. This laundry was, money for this laundry was sent by a faith-based group in Europe to this community, and the man went into the laundry business. He put this beautiful laundromat in place. He did all my laundry for about 20 cents. If I could, I would continue to send my laundry to him. It was beautifully done and for a very good price. This lady opened a little cottage industry. She started to sell clothing. So watch what she's doing. She's painting the designs on the clothing using a sewing machine like our grandparents, well, my grandparents had. Some of you would be great-grandparents. A foot-operated Singer pedal machine to make these beautiful dresses and sell them, and these beautiful shirts. And so people are resilient. People can come back. The temporary housing that was put in place that seems so unappealing, metal housing, poor ventilation, hot as can be, in a few months' time, banana trees grew. People had planted their gardens and adapted. People can adapt. People are resilient. In Aceh, in Indonesia, it didn't go quite as well. Remember, the tsunami affected Thailand, Indonesia, and several places. We got a grant from the Robert Wood Johnson Foundation to work in this community to do some environmental capacity building post-tsunami. One of the overlying challenges, though, in this community was the ongoing Achean rebel conflict. This is an area that's been in conflict for decades. And literally every day, 30 to 40 or 50 people get shot and killed in daily conflict in this region. It gives you pause as you go into this region to try to do public health, realizing that the biggest risk after you evaluate everything is not a public health risk, it's getting shot. This is the University Administration Building. It was destroyed during the tsunami and the earthquake. It was rebuilt with European community funds. The Achean rebels were disappointed that they were not part of the resources that were sent into the community to build this. It was dedicated in the morning and burned down again in the afternoon by unhappy people. This is a Meneska, or little mosque, out in the rural area in Banda Aceh, and we're having a community meeting. We're having a discussion with folks. It's very traditional. The ladies are on one side, the men are on the other side, and we're asking them, what are the risks? What are the health problems that you have? And surprisingly, the three risks, one of them was poor diet, poor nutrition. And so these are two of our nurses on the project, and they are talking about the food pyramid and just basic information on how to eat more healthy. And you would think that, in a rural community that's growing most of its own food, that wouldn't be an issue. It was clearly an issue. The second issue were dental caries. Soda is consumed in very high amounts, and so the little ones already had very, very poor teeth, very high number of cavities in their teeth, even in the primary teeth. And the third thing, of course, is lack of infrastructure. The marketplace had been destroyed in the tsunami and the earthquake, so now we have eggs out in the heat in about 110 degrees. Once again, though, people are resilient. This man had a factory. He lost it. He was a furniture maker, and we visited his factory. Now he's making a delivery, and he has 11 benches on that motorbike. And that's his son behind him, and he very proudly said to me, my son isn't really quite as good a driver as I am. He can only carry 7 benches, but I can carry 11. And I said, okie doke, that's progress. So in global health, our challenges are to serve the next generation, to have adequate water, to have adequate food, to have resources that are managed well so that their children can enjoy a healthy environment. 1 in 5 kids around the world die of diarrheal disease from lack of clean water. Malaria still claims 1 in 5 children in many parts of the developing world. There's lots of work for us to do. And these beautiful little kids here represent our biggest challenge. So I'm going to end with a couple little funny notes, and then we'll take some questions if you have them. So I've been doing this a long time, and I continue to be in awe of how the system works. Every time I go to the place, even if it's a place I've been many times, I learn something new. We talk about the fact that we don't have enough food for people around the world. We actually do. We don't distribute it properly. This is a floating market in the very southern tip of Vietnam, and this is the food distribution. About a third of the global food supply is destroyed by insects and rodents and diseases. We have enough food. We don't have a mechanism to deliver it. So what are we delivering? Well, we're delivering fast food. That's why Thailand now has a 9% of their population is obese, and the government's declared a national emergency. Fast food is everywhere. I was told when I was in Myanmar that they didn't have a McDonald's yet, but they did have their first Pizza Hut, and the McDonald's was soon to follow. And here you see Ronald greeting you with the traditional Thai Y as you come in, and as you can see at the corner of the sign, thankfully this McDonald's is available 24/7. Traditional street food is probably not a lot healthier in some places, but it is there. Sometimes when you travel, you learn to experience different kinds of food, like this slide. In Vietnam, we had a banquet in our honor, and they said, Dr. Robson, would you like a menu in English? I said, no, I'm good. They said, no, we can get you one. I said, no, everything's fine. It's delicious. Everything's good. Remember how your mother told you, just be polite, eat everything on your plate. this menu appeared, and if you look at the top of the menu, you can see what appeared. Mouse. Mouse meat with raw mango, mouse meat with lemongrass. I was doing okay till I realized it was mouse. Then I got a little anxious. And with a straight face, the young graduate student said, "Do not worry, Professor. It was a happy mouse. He lived a good life. He ate rice in the rice paddies." I said, "Well, he doesn't look particularly happy here on this plate this evening, but he didn't taste too bad either." I try to go for the fruit and vegetables when I can. But, you got to try some things new. You are eating parts of animals that you normally don't eat, like pig's ear, a little bit crunchy, pig's intestine, a little bit crunchier. And you also find that you become the center of attention, which there's several people on this webinar that know me well know that's something I love to be. And this is one of my favorite little stories as we come to the very end of our talk, is I was in Saigon, and there was a large cathedral there, and I asked if I could see what it looked like inside. Many Vietnamese people are Buddhists. A large number, 7% of the population is Catholic. And so this big Catholic cathedral was there in Ho Chi Minh City, what you and I know as Saigon, and I went to visit. As I came out, there were a whole lot of young men and women in a queue getting ready to go in and get married. And so this young man asked me over and said, "Would you take some pictures with us?" So I took a set of pictures with the bride and the groom on their wedding day, and the next thing you know, all 7 couples invited me to be in their wedding photos. So when I came home and I was showing these slides to my family, my wife said, "You're such an idiot." I said, no. I said, "That's not fair." I said, "You might think this is silly." But I said, somewhere in Vietnam there are 7 couples showing pictures of their wedding day, talking about this great big guy they found from the United States that's in each of the pictures. So it was an honor for me to be in their wedding photos. And the biggest honor I got after all these years of doing environmental health on a global basis was an honorary degree. This is my honorary degree from Chulalongkorn University in 2010 from the Crown Princess. And it was just the highest, it was the best day of my years in public health. Interestingly, the princess and I are about the same age, both April 55 babies. And she was very gracious and very kind. They asked me, what would I like to bring her? And I said, well, what does the princess like? And they said she loves to read books. So that's a copy of Robson and Toscano, Environmental Health Risk Assessment. And she promised me that she would read it. And I'm sure that she did. So we have 10 minutes for questions if you have them. If you don't, that's fine too. They'll appear up on the screen if you type them in. And let me know if we can answer any questions. Or also, if you have a comment to make, I'd love to share the comment with the rest of the group. And so, my wonderful graduate student, Dawn Marling, is typing something. Okay. Very proud of Dawn. She got her MPH with me. All right. Multiple attendees are typing. Let's see what we're going to ask. Remember, Dawn, I don't know much, so don't ask me a question I can't answer. Nothing's popped up yet. Here it comes. Oh, a very kind comment from my wonderful student, Dawn, saying she misses me. And I miss you too, Dawn. You work so hard to do a wonderful job with your MPH. So thank you very much for that kind comment. Okay, here's another one from Danielle. Spouse watched the program with me. He's environmental health spouse. Oh, very nice. Very good in USRBN. Excellent. Okay. Thank you, Danielle. So a couple of you, while the next one is popping up here in typing, some of you who actually were my students notice there's a little bit less of me than there used to be. That picture at the mosque is probably one of the ones that I should probably try to Photoshop. That's where I weighed over 300 pounds. So I'm not sick. I got an email the other day. Someone saw us post on Facebook and said, "Dr. Robson, you lost a lot of weight. Are you sick?" I said, no, I intentionally worked very hard to do that. So I've lost about 130 pounds and still have a little bit more to go. But if you want to know how to lose the weight, you can send me an email sometime and I'll share that with you. Mitchell, can we scroll down one more? Or do you know how to do that? Or do you do that for me? Here we go. Oh, they're still typing. Okay. Tamara is still typing. Here's the name.
Danielle has a question.
Okay, yeah. What program developed in the care of children exposed? What program developed in the care of children exposed? Oh, so the three things that we did, excellent question. The three things we did is the first thing is we instructed the kids, because kids are better learners than their parents, you know that, on just how to stay out of the field and not to play in the field. So one of the things was we talked to them about healthy play, that you don't play at the edge of the field, you don't run into the field next to the sprayer. Now, you know, a lot of us, and this is about the time of year that these pictures reappear on Facebook and on the internet, when some of us who are old like me would pedal their bicycles behind the mosquito sprayer at the Jersey Shore. So the same sort of thing. We said to these kids, you know, that's something you don't want to do. You want to stay out of the field. You don't want to be playing at the edge of the field while mom and dad are spraying to get caught up in the mist. It's not a fun thing. It's a dangerous thing. The second thing we talked about was just basic good hygiene. Washing your hands, and in this case your feet, but especially your hands, before you put things in your mouth, because that's the easiest way for them to come in contact with some of these pesticides. And the third thing, and I trimmed the email me anytime that you want, ROBSON at Rutgers, RUTGERS.edu. I'd love to hear from you to talk about this, or if you want to come back to graduate school, or whatever you'd like to do. Okay, be well, be safe.